Good afternoon and welcome to today's presentation about quote-unquote recovering from COVID. Obviously, medical practices are under tremendous strain as a result of the pandemic. This is really no different than other segments of our economy, but in addition to running a business, medical practices have the added burdens of treating patients in this new safety paradigm, whether those patients have or don't have COVID-19. And the medical practices must do so in a highly regulated healthcare industry. Any COVID-related topic would take much more time than we have today to discuss. So as I worked through topics that might be of interest for you, I settled on issues that might not be at the forefront of your mind or of your medical practice or its professionals. But those issues still remain critical to ensure the practice remains in compliance with its various business obligations and more importantly, remains able to help and treat patients. This becomes especially important if the practice modifies arrangements with other healthcare partners or receives any type of relief funds under the CARES Act or otherwise. So let's talk about a few ways for practices to stay ahead of the curve in this COVID environment. As you will have seen from the conference agenda, my name is Kevin Wood, and I am a shareholder in the Austin office of Winstead PC. I've practiced law solely in the healthcare space for almost 20 years, but have been part of the Winstead family for only about 6 months. My Austin team and I moved together, and we are extremely excited to be with Winstead. And I am extremely excited and honored for the opportunity to talk with you today. Thank you for taking the time to participate and to listen for a few minutes. And thank you to Texas MGMA for giving me this opportunity. Of course, no presentation by a lawyer would be complete without some sort of legalese, so here it is. When I'm giving these types of presentations in person, this slide and short discussion usually brings a chuckle, and maybe a few rolls of the eye. Hopefully it did that for you wherever you are listening today. In all seriousness, though, I would be remiss if I didn't point out the following. Today's discussion is general in nature and provides only an overview of what could apply in your given situation. While we're discussing legal principles today, the compliance obligations and requirements for each of you depends on your specific facts and circumstances. I can point out the steps that you may need to take to be in compliance, but this presentation does not create an attorney-client relationship, and most importantly, you should remember that nothing can replace the sound legal advice from your trusted counsel. With that out of the way, let's outline what we will be discussing today. Again, medical practices and professionals have multiple strings pulling them in multiple different directions. So for the next 50 minutes or so, let's take some brief time to look at 3 different items. First, some of you may have arrangements with parties with whom your practice or its physicians may have financial or referral relationships. As you're aware, those arrangements are subject to fraud and abuse laws, namely the federal anti-kickback statute and federal physician self-referral prohibition, also known as the Stark Law. To facilitate ease in revising arrangements that may be subject to these laws during the pandemic, let's say, think of a medical office lease in a building owned or affiliated with a hospital, or a medical directorship with a hospital to which the physician refers, or the need to enter a physician recruitment arrangement in short order. Well, in all of these instances, the pandemic requires quick action. So the Office of Inspector General for the U.S. Department of Health and Human Services, or the OIG, and the Centers for Medicare and Medicaid Services, CMS, adopted blanket waivers for the anti-kickback statute and Stark Law, respectively. We will talk about these in turn and steps you should take as the pandemic continues. Second, some of you may have received provider relief funds, either as part of Medicare advanced or accelerated payments, or from the distributions granted under the CARES Act. By accepting these dollars, you have certain obligations that are coming in quick succession. We will talk about those obligations. And finally, something not really related to COVID-19, but happening as quickly as January 1st, 2021 nonetheless, changes to the evaluation and management coding and work RVU values. While mostly good news for medical practices, there are also some pitfalls. You will likely hear more about this in other sessions of the annual meeting, and we hope our guidance will augment the greater detail in those sessions. So let's get started. If you're like me, you're tired of hearing the news each day about the progression of COVID-19. If so, I apologize in advance for the next slide, but believe it is important, really important, so that we keep the current situation in context from a patient impact perspective. Through last week, we had over 6 million COVID-19 cases confirmed in the United States, with slightly over 10% of those cases here in Texas. An even more grim reminder from the statistics is that we are approaching nearly 200,000 deaths from COVID-19, with over 13,000 of those occurring in Texas. For comparison, the Centers for Disease Control and Prevention, the CDC, estimated that the most recent flu season from October 2019 through early April 2020 had between basically 40 and 55 million cases of flu in the U.S., with anywhere from 24 to 62,000 deaths attributed to that virus. While COVID-19 hasn't been as prevalent as the flu, it has had a more significant impact and looks to continue to do so until a vaccine can be developed. The issues surrounding these statistics could be the subjects for a number of discussions, and I don't raise these numbers to put a damper on today's discussion. Instead, I include them to demonstrate why COVID-19 is putting such a unique strain on our medical system and the legal issues that providers still must face despite this strain. And besides raw numbers of individuals directly contracting or dying from the disease, medical practices have been adversely impacted by things such as executive orders that close their businesses or limit the types of services they can provide, or the types of procedures they can perform for patients. They're also impacted by hospital reductions or shortages, and especially things at hospitals are overflowed that adversely impact how medical professionals can serve patients. These don't even address or really address the impact of physician practices that are not directly involved in the treatment of COVID-19. The impact of dentists, chiropractors, or podiatrists who are not in the medical field and are probably not treating COVID-19 patients, or the issues that arise from vulnerabilities that are facing patients in the long-term care setting. The list goes on and on and on, so I can sympathize with the burdens that you're facing. As we discuss today's topics, it's important to consider them in context of everything else that you and your professionals may be encountering. So let's take a look at the anti-kickback statute and Stark Law waivers. Usually, when I've been having these discussions, I'm discussing fraud and abuse considerations in the COVID-19 context. Really, in the COVID-19 context, it's real estate concerns, especially for relief under existing lease and other real estate arrangements. But as you know, fraud and abuse laws must be considered if there's any type of referral relationship between the parties to an arrangement. And those laws that we have to keep in mind are the federal anti-kickback statute and the federal physician self-referral prohibition, also known as the Stark Law. These issues can include a number of situations when hospitals or health systems act as landlord, when the landlord entity may be owned by one or more physicians, when joint venture arrangements require different actions in response to COVID-19 or the restrictions that have been implemented because of COVID-19, when physician service or recruitment arrangements require reassessment, or a multitude of other situations that involve referring parties. While today's discussion focuses on anti-kickback and Stark Law considerations, please keep in mind that other healthcare laws, namely state-specific healthcare laws, may come into play. Those must be analyzed in line with any assessment of anti-kickback and Stark Law issues to make sure that you do not create any other requirements that must be included in any eventual arrangement. As many of you know, both the anti-kickback statute and Stark Law contain safe harbors and exceptions, respectively, for a number of arrangements. Usually, healthcare parties structure their arrangements to satisfy an applicable anti-kickback safe harbor or Stark Law exception. Back in the spring, CMS provided some relief to such arrangements through blanket waivers under the Stark Law, and the OIG followed suit in issuing a policy statement that will exercise its enforcement discretion not to impose penalties under the anti-kickback statute for payments covered by the Stark Law blanket waivers. Because these laws and the relief under these laws during the public health emergency have different requirements and purposes, we're going to discuss each of them in turn. When discussing the anti-kickback statute or Stark Law, I generally start with the Stark Law because it is more limited in scope. But under the blanket waiver relief, the OIG is relying on the Stark Law blanket waivers as its basis to forego anti-kickback enforcement. So we're going to start with the anti-kickback statute and then move to the Stark Law discussion. In the most general terms, the anti-kickback statute prohibits any offer or exchange of a benefit that could be construed to induce or reward referrals or other business involving items or services payable by federal healthcare programs including Medicare, Medicaid, and TRICARE. Because the anti-kickback statute is an intent-based statute, the burden of proof for compliance is on the parties to the arrangement, and the parties must be able to show that the substance of their arrangement follow anti-kickback requirements. For space leases, as an example, that guidance rests with the lease of space safe harbor, and the primary concern under that safe harbor is that the rent is fair market value for the space leased and does not take into account the volume or value of referrals or services exchanged between the parties. When changing the amount of rent payments or providing other relief under a lease, that could change the fair market value nature of the arrangement. The good news, though, is that absent a clear intent of fraud under the arrangement, the OIG policy statement would allow for relief during the COVID-19 emergency. And this same type of fair market value analysis would apply in situations involving equipment leases, personal services agreements, and other compensation-related arrangements. As we will discuss shortly, the parties will need to analyze and document how the changes to an arrangement remain in compliance under the anti-kickback statute. Again, the Stark Law is more limited in scope than the anti-kickback statute. While the anti-kickback statute covers a variety of governmental healthcare programs and applies broadly to a number of arrangements and types of parties, the Stark Law requires a physician to be involved in the arrangement and requires that designated health services, or DHS, payable by Medicare be in the mix. More specifically, the Stark Law prohibits a physician from making referrals for DHS, and that can include such things as lab services, imaging services, physical therapy, and hospital services. It prohibits that physician from making referrals for DHS payable by Medicare to an entity that the physician or an immediate family member has a financial relationship with, unless a Stark Law exception applies. The prohibition also prevents the DHS entity from submitting a Medicare claim for an improperly referred DHS. Similar to anti-kickback safe harbors, the Stark Law has specific compensation exceptions such as the space or equipment lease exception, the personal services exception, the physician recruitment exception, etc. Each of the Stark Law exceptions has specific elements, and unlike an anti-kickback safe harbor, which can be met or not without violating the anti-kickback statute, each and every element of a Stark Law exception must be met to escape violation of the Stark Law. For many of these exceptions, they include items such as a written agreement, specific terms about the arrangement and compensation that's set in advance, fair market value, and not based on the volume or value of referrals or other business between the parties. Because of the impact of COVID-19, you and other parties may be considering how to adapt arrangements to the new reality, and any change to the term or compensation under the agreement could change the fair market value nature of the arrangement or otherwise keep the amended arrangement from meeting the applicable Stark Law exception. Without waivers or exceptions, Stark Law violations would occur. With that in mind, the OIG issued its policy statement on April 3rd, 2020, and CMS acted the Stark Law blanket waivers on March 30th, 2020. Both agencies' actions were within their discretion under the COVID-19 public emergency declaration by the Secretary of Health and Human Services. For the Stark Law blanket waivers apply nationwide and are intended to ensure the availability of healthcare services to Medicare and Medicaid beneficiaries and to allow healthcare providers to receive payment for certain claims that would otherwise violate the Stark Law if the waivers weren't in place. In issuing the waivers, CMS listed examples of revised lease arrangements as examples of arrangements that could result in failure to meet the applicable exception. These include activities such as payment of less than fair market value rent, remuneration to a physician tenant in the form of rent abatement, deferral of forgiveness of rent that could result in rent that was no longer fair market value, or remuneration resulting from a loan by a DHS entity to a physician tenant to pay rent that would include a below-market interest rate or other terms that would be unavailable from a commercial lender that doesn't receive referrals from the physician tenant. Similar considerations would apply to other types of arrangements. To take advantage of the Stark Law blanket waivers, which does not require any request to CMS to use, by the way, the arrangement must be for a valid COVID-19 purpose, which is defined in the blanket waivers. In the case of a lease arrangement, for example, the parties will need to demonstrate how the relief, whether rent deferral or reduction or overall abatement, is appropriate as relief because of COVID-19. It's unlikely that abatement of rent for the remainder of a lease, as opposed to limited deferral or reduction to allow the physician or practice to keep its doors open, would qualify as appropriate relief. With the Stark Law blanket waivers and OIG policy statement in mind, what steps should you and the other parties take? Because any changes in the arrangement must be for a valid COVID-19 purpose, the parties should analyze and document the reasons for the arrangement. They should also document the specific terms of the revised arrangement and how the arrangement qualifies for the blanket waivers. We'll discuss a few other best practices, but if you take one item away from today's discussion, let it be this: document, document, document. CMS extended the waivers to providers so they could continue services through this time of emergency. But policing and auditing the use of the waivers will come after the fact. Documentation will be key to demonstrating compliance. As a result, we recommend some best practices for this process. First, develop and establish a policy or protocol to ensure that all requests to revise any arrangement are evaluated on the merits of the particular request and that any financial assistance granted is not tied to the volume or value of referrals or other business between the parties. Second, develop the business case for the arrangement, which could include documentation that without assistance, the tenant or party would no longer be financially viable. And third, if possible, as facts and circumstances warrant, obtain a third-party opinion on the fair market value and commercially reasonable nature of the arrangement. Finally, it's really important to remember that the Stark Law blanket waivers and OIG policy statements are not permanent. Absent extension or grandfathering, the blanket waivers and OIG relief will end when the public emergency declaration ends. From all this, and as you are well aware, Stark Law and anti-kickback compliance can be complex. So before we turn to our discussion points regarding provider relief funds, I want to close this segment with a few reminders. First, the reach and application of the anti-kickback statute is much broader than the Stark Law, and the OIG deferral of enforcement is solely tied to the party's ability to show compliance under the Stark Law blanket waivers. Because of this, and secondly, the OIG will continue to enforce truly fraudulent arrangements and could enforce sanctions if the parties can't demonstrate that the arrangement was for a valid COVID-19 purpose under the Stark Law blanket waivers. It's also important to note that the dates of application of the various reliefs are different. The Stark Law blanket waivers are available retrospectively back to March 1st, 2020. But the OIG deferral of enforcement is only applicable to arrangements on and after April 3rd. That's the date the OIG policy statement was issued. So while the OIG offers its relief under the anti-kickback statute so that parties have some consistency in application between the two laws, parties must still keep the applicable effective dates in mind. I mentioned this a minute ago, but please remember that the relief under the anti-kickback statute and Stark Law will end when the public emergency ends. That means that if you've made a change and you're taking advantage of these waivers, you'll need to be prepared to terminate the arrangement or restructure it to come into compliance with the appropriate Stark Law exception when the public emergency is over. And last and most importantly, again, document the arrangement so that you can easily provide written support of compliance to CMS or the OIG when asked. So in talking, we've gone through a few things with those blanket waivers, which hopefully some of you have been able to take advantage of. But what about provider relief funds? Did you apply for Medicare Advanced or Accelerated Payments? Were you one of those practices that received relief funds under the number of distributions provided by the CARES Act or the original stimulus package? Either way, strings still came attached to those relief funds, so let's make sure you have the information needed to unravel those strings. Unlike provider relief funds under the CARES Act, Medicare Advanced Payments or Medicare Accelerated Payments actually required application from you as providers to receive funds. And unlike any funds received under the Payroll Protection Program or PPP, which are also a loan, but are going to be forgiven if used for employee expenses within the applicable period among its other requirements, Medicare Advanced or Accelerated Payments will not be forgiven. In fact, both advanced and accelerated payments are considered loans from CMS, and the repayment obligation is included as an automatic recoupment for all Medicare payments starting 120 days after receiving the initial payment. If you applied for and received advanced or accelerated payments, you have likely entered that recoupment phase or will do so soon. For example, September 1st or so would be the trigger date for recoupment of funds received around May 1st. House and Senate measures have included options to delay or lengthen this recoupment period, as well as addressing the interest rate on any funds after recoupment ends. But as you know from the news, unfortunately, another stimulus bill remains in limbo, so recoupment remains automatic and at the mercy of action by Congress. CMS initially indicated in rollout that it would consider allowing something less than 100% recoupment for certain financial hardship cases, but to date, neither CMS nor any Medicare Administrative Contractor, or MAC, has issued information on the process for financial hardship consideration. Understandably, this is difficult news for providers who must now find ways to survive financially during this difficult recoupment phase, or find ways on their own to request the financial hardship through their MAC or through CMS. If you need to do so, please rely on effective counsel or advisors to help. Despite the struggle that comes with advanced or accelerated payments, there is some good news under the CARES Act in that a significant, albeit not likely sufficient amount of relief funds have been issued to providers. Unlike advanced or accelerated payments, these provider relief funds are grants and not subject to repayment. Original funds in Phase 1 were automatically issued in April and May 2020 by direct deposit or direct check and were based on the provider's share of total Medicare fee-for-service in 2019. For example, under the given formula, a physician practice that billed $1 million under a single tax ID number in 2019 could have received almost $62,000 in provider relief funds. And a large practice that billed $25 million under a single tax ID number in 2019 could have received over $1.5 million. As you will see as we go through the discussion, the amount received will trigger different reporting and audit requirements. As of August 10, 2020, HHS, or Health and Human Services, reopened the general allocation portal for Phase 2 distributions up to $15 billion for eligible providers in COVID-19 hotspots and for providers participating in Medicaid CHIP programs, Medicaid managed care, dental providers, as well as Medicare providers who may have missed the original round of distributions because of a change of ownership in 2019. My guess is that many, if not all of you, received provider relief funds from the general distribution. And while provider relief funds likely provided a much-needed lifeline, no pun intended, they are not free money. Failure to use the funds appropriately and in accordance with the terms and conditions could result in exposure to government audits and False Claims Act investigations, including possible key TAM litigation. Accordingly, the importance of the compliance obligations related to provider relief fund payments cannot be overstated. So a little more detail. If you received provider relief funds, you must submit attestation within 90 days after receiving each payment. The attestation confirms receipt of the funds and your agreement to use the provider relief funds as allowed under the terms and conditions. If you choose not to keep the funds or abide by the terms and conditions, you must reject the funds and remit full payment back to HHS. If you receive provider relief funds, most of you would have already completed the attestation steps via the online attestation portal. But if you happen to miss the time window and kept the funds, no worries. Failure to either return the funds in full or to attest within 90 days to the portal results in deemed acceptance of the provider relief funds and agreement to the terms and conditions. So what are those terms and conditions? As you would guess, there are several. First and foremost is how you use the funds. In short, providers must certify that they use the funds in the diagnosis, testing, or care for individuals with possible or actual cases of COVID-19. And the good news is that HHS views the COVID-19 purpose very broadly, such that every patient could be a possible case of COVID-19. The providers must certify that they use the funds to, quote, prevent, prepare for, and respond to coronavirus, and that the funds will only be used to reimburse healthcare-related expenses from COVID-19 or lost revenues from COVID-19. And the providers must certify that they did not use the funds for any expenses or losses that were reimbursed from other sources or obligated to be reimbursed from other sources. We'll turn to a quick discussion of healthcare-related expenses or lost revenues in a second, but I want to take a moment to emphasize that neither HHS nor CMS has prescribed a process or checklist for making these types of designations. Instead, you should have a process in place that allocates profits and losses in line with COVID-19. It doesn't have to be a super elaborate process, but should be reasonable in line with your common policies and procedures. If you can simply add line items specific to COVID-19 and allocate expenses, all with supporting documentation, of course, that should be sufficient. For example, create a new folder for use by your team for documents to show both what you're doing and why you're doing it. Or create new software reports or other reports that show effective audit trails for use of the funds. The key at the end of the day is to be able to demonstrate the reasonableness of what you've done. Again, document, document, document is the mantra. For those healthcare-related expenses, this is a long list of items that can qualify. Equipment, supplies, training, emergency operation centers, new treatment locations, whether they're for COVID-19 patients or to protect other patients from COVID-19 patients, acquiring multiple types of additional resources. The list goes on and on. The key is being able to demonstrate that you incurred the expense, quote unquote, in response to coronavirus. Some type of allocation system, such as marking invoices for COVID, etc., is in order. Again, it should be a reasonable system within the capabilities of your operations. In addition to healthcare-related expenses for COVID-19, provider relief funds can also be used to cover lost revenue from coronavirus. This should involve a reasonable process that compares expected or historical revenues to decreased revenue from coronavirus. For example, You can calculate the lost revenue from office closings, canceled procedures, or added uncompensated care for uninsured patients. Each of you have had different situations as to your revenue expectations for 2020, so your determination of what would be lost revenue will each be different. The key, which I can't overemphasize, is that whatever allocation system you choose, let it be something reasonable for your operations and something that you could easily explain to HHS if asked to do so. And you should document your processes as if you expect HHS to ask. Back to the use of funds. On top of the processes to show your use of the funds for healthcare-related expenses or lost revenues, you cannot use relief funds for prohibited purposes. This includes such things as paying individual salaries in excess of the $197,000 threshold there, or an appropriate percentage of that amount, depending on the full-time equivalent ratio. And I'm going to take a break here because this is a good way to tie provider relief funds back to other funds that you might be obligated to reimburse you. For example, if you received a PPP loan for employee salaries, you should allocate the PPP for those salaries, and you shouldn't be allocating provider relief funds to salaries that the PPP would reimburse. But here, even if PPP was not enough, or you've extended past that 24-week period and you still need help with expenses, you can use this. You just can't do it in a way that exceeds the threshold at the executive level to amount. Other prohibited uses include using relief funds for lobbying, funding abortions or needle exchanges, or any type of embryonic research. Likewise, you can't do business with anybody who requires, and you can't require, employees not to report suspected fraud, abuse, or waste of federal dollars. And then finally, you can't do business with corporations with unpaid tax liabilities or who have been convicted of a federal crime in the prior 24 months. And this is where I want to take a few minutes on that last piece as a demonstration of how your documentation process is going to have to be amended or strengthened in real time. So you have these provider relief funds, and because of that, you have to ensure that you're not doing business with a corporation with unpaid tax liability or a potential federal crime in the mix. And that's going to potentially require some changes to your vendor contracts or your vetting process for vendors, because most of you are going to be used to searching the exclusion database to make sure that no one or somebody you do business with is not excluded from Medicare. But that's probably not going to be enough for this last point, because the database only deals with individuals excluded from Medicare or other federal programs. It doesn't address federal tax liability or federal crimes. So you're going to have to ask different questions, and contracts may require updated representations and warranties on these types of issues, along with what would already be in place. So that's where this real-time assessment comes into play. Finally, you can't balance bill for COVID-19 patients. And this is really going to apply when you have this option or the significant number of patients who are out of network. The good part of this is this provision has been clarified to only apply for actual COVID-19 care. So that means it only applies to patients who actually have COVID-19 or who are presumed to have COVID-19. For those patients, you can only charge the amount the patient would otherwise be required to pay if care was provided by an in-network provider. And you can't seek to collect out-of-pocket amounts from the patient in any amount greater than what would be an in-network amount. This, of course, doesn't prevent you from submitting a claim to the insurance company and seeking applicable payment, but it does mean that you have certain limits to what you can charge a patient or collect from a patient. It also raises a valid question of whether the balance not billed is a healthcare-related expense or a lost revenue. If you have a significant out-of-network patient population and this is a real issue, you should develop a reasonable allocation process based on historical patient payments, insurance payments, etc. The key is reasonableness to the accounting process and the supporting documentation for it. Along with abiding by the terms and conditions, providers that receive relief funds also have reporting obligations. Several weeks ago, HHS distributed a notice to providers telling them about expected reporting requirements for using provider relief funds. If you received those funds, you should have seen this notice. Both the CARES Act and the terms and conditions for the provider relief funds require those receiving more than $150,000 to report quarterly on the amount of funds received and how the funds were used, along with appropriate documentation. Providers receiving up to $150,000 must report when and if requested by HHS. Well, on June 13, 2020, and right before the first reporting deadline on July 10th, HHS issued a frequently asked question informing recipients that they did not need to provide the quarterly reports because HHS was preparing a report with the needed information to allow fund recipients to meet the requirement, and that HHS would issue future guidance on needed reporting requirements. HHS initially released that guidance on July 20th and most recently updated it on August 14th. Basically, it provides that those who receive more than $10,000 in provider relief funds must report on the amounts and uses of any funds. Actually, in the words of HHS, to quote, allow providers to demonstrate compliance with the terms and conditions, including use of funds for allowable purposes, unquote. Unfortunately, HHS has still not released the specific details of the reporting requirements, but says the details will soon be coming from the Health Resources and Services Administration, or HRSA. Originally, the details were to be released by August 17, 2020, but that recent notice removed the date and left the timing open. HHS assures providers that HRSA is continuing to refine its data elements and will provide additional details prior to October 1st, 2020, the date when the reporting system is set to go online. So while we wait on those details, please remember and note the following timing and likely back-end dates to report on uses of provider relief funds. If you receive provider relief funds, you must report on expenses through December 31st, 2020, within 45 calendar days after year-end. Right now, that falls on Monday, February 15th, 2021. If you spent the funds in full prior to December 31st, you may submit a single final report at any time during that window that begins October 1, when the portal opens, but no later than February 15th, when 2020 expenses have to be reported. The good thing is that if you have flexibilities to spend funds in 2020 and into 2021, so if some of that spending goes into 2021, you just have to report the 2020 expenses by February 15th, and then you have until July 31st, 2021 to submit a final second report. Really, the gist of that is please make sure that you keep in mind and pay attention to HHS and HRSA for updates as they come out. Well, as if those reporting requirements didn't seem onerous enough, HHS has also indicated, both through a notice to relief fund recipients on its website and through recently released FAQs, that recipients of provider relief funds, and that's all provider relief funds, whether general or targeted or uninsured testing and treatment, if those relief funds are in excess of $750,000, the provider is going to be subject to federal audit requirements under 45 CFR Part 75 Subpart F, which means that that dollar amount is considered a federal award. This audit obligation is not limited to nonprofits or state and federal agencies, but includes for-profit and commercial recipients that would involve most medical practices if they happen to be large enough to receive that size of provider relief fund amount. Generally, those providers receiving relief funds in excess of $750,000 must obtain an annual third-party audit of their compliance with the award terms and conditions. And this audit will typically either be a single audit for all the entity's federal awards, or a program-specific audit when there's only one award among several different things. Because of the timing of the provider relief funds and the nature of the rule over the audits, it could be that you have an audit obligation still within 2020, but if there's an audit due before June of 2020, based on when you got the funds, you've been granted a 6-month filing extension. And if it happens to fall in between July and September of 2020, there's a 3-month extension. You'd also want to make sure that you pay attention to the audit rules and the audit procurement rules if you have to get an auditor. Those are also outlined in the statute in the CFR section. Basically, you just really need to pay particular attention to this audit piece if you fall into that limited group of providers that receive $750,000 or more in provider relief funds. And this will put an additional burden on your compliance with the terms and conditions, as well as the reporting requirements already discussed. And throughout our discussion of the provider relief funds, its terms and conditions, and its reporting or audit requirements, I focused on the reasonableness of the processes you put in place. Not only is that important for your overall reporting obligations, it's also important to prevent an even larger problem that can come from a disgruntled or ignored employee in the process. While penalties from improper use of relief funds could be substantial, such improper use could also open your practice to false claims liabilities. The Federal False Claims Act is often discussed in compliance training in conjunction with the anti-kickback statute and Stark Law, which we discussed earlier, and that's mainly because of its larger penalty potentials. But it has a much longer history than either of those other two laws. The False Claims Act was originally enacted during the Civil War in response to vendors who were supplying faulty items and services to the United States and the Union Army. It's since been revised and amended several times, and it's been broadly extended to false claims, records, or statements in the healthcare context. This would now include receipt and reporting on provider relief funds. While the possibility of treble or 3 times damages is significant, the more significant piece of the False Claims Act is that individuals, that is whistleblowers, can raise complaints on behalf of the government. And if those allegations are successful as to false claims, the whistleblower or key TAM relator receives a piece of the pie. This is where that disgruntled or ignored employee enters the mix. When developing your action plan for provider relief funds, it's important to develop the plan with a team. But it's even more important to listen to that team. If someone raises questions or concerns over use of the relief funds, address the concern and document the response to any raised concerns. If possible, get the person who raises the concern to sign or acknowledge that he or she agrees with and accepts the response. This is so important because you will often find out about a whistleblower action after it's too late. These types of actions are filed under seal, and the government has a period of time, including the time to investigate and build a case, before it decides to enter the case and unseal it. And even if the government chooses not to participate in the case, the whistleblower can still proceed if he or she believes it is a valid case. While you will likely know about the case by this point, you will spend significant resources to defend and resolve the case. As with medicine, an ounce of prevention is worth more than a pound of cure. Finally, and not to belabor the point, here's a list of potential risk areas that could lead to a false claim allegation. And note the determination of improper use of provider relief funds will likely qualify as a valid basis for false claims liability. Yikes, that's enough doom and gloom. Hopefully this topic won't sound or be as burdensome as the first 2 topics. Let's look briefly at the coming changes for Evaluation and Management Guidelines, or E&M codes, set to take effect in 2021. As I recall, other sessions in the MGMA annual meeting will address coding matters, so I'm sure they'll discuss this issue in much more detail. I just want to give you an overview and provide some thoughts for you to consider as you prepare for these changes. In fact, I hope these changes will offer a glimmer of hope to you as you look forward to 2021. I know COVID-19, along with the topics that we've already discussed today, may have resulted in you not really focusing on this issue. So if you are not already aware, the most significant evaluation and management E&M guideline change for ambulatory practices in over 20 years is coming on January 1st, 2021. In fact, two critical facts exist for every healthcare organization to know as to these changes. One, the E&M coding changes are going to require action by every healthcare provider. And two, unlike many changes that often add burdens or create new challenges, these updated E&M guidelines present positive changes that providers can take advantage of. We don't really have enough time to go into things in detail today, and again, other sessions should shed more light for you, but this information should provide a good synopsis to get you going in the right direction. These E&M guideline changes are a collaboration between the American Medical Association and CMS, both of them focusing on the Patients Over Paperwork initiative. And while the changes don't go into effect until January 1st, 2021, now is the time to prepare for the changes. In overall summary, the new guidelines affect only new and established office and outpatient E&M codes 99201 to 99215. But even with the changes limited just to these codes, they will significantly change documentation of the patient visit. The changes remove the history and exam as key components and instead base the code level selection on either medical decision-making or time in the visit. That's it. And I chuckle because that sounds too easy, because it is. You're going to have a lot easier medical record documentation, and you're probably going to see financial benefit from the changes. All of those are positive. But you also need to make sure that you understand that changes to your underlying systems to document all of that or to support the code level selection may not be as easy. As an example of the positive nature, here's where things are going to stand with the current guideline proposal. In general, code 99201 has been eliminated and code 99211 has been unchanged, but the changes for 99202 to 99205 and 99212 to 99215 will likely result in increased reimbursement since the work RVUs for these codes have been increased quite a bit. This is despite the fact that the change is meant to be budget neutral and the Medicare compensation rate has been decreased from roughly $36 to $32 and some change. That said, physician compensation based on work RVU productivity will certainly be affected, often to the good. And while this change only shows the changes for Medicare, major commercial payers have not yet announced their intentions on using the 2021 E&M codes. They likely will, and those decisions are likely to come soon. And as a result, that will also have a big impact on provider reimbursement and work RVU utilization. So again, this change requires much more time and detail than we can give it today, but hopefully this checklist can prepare you within your own practices. So what can you do? First and foremost, take a look at what you're currently doing and then create those processes as a benchmark. Second, determine whether the new E&M coding can be supported by your current documentation processes. If so, that's the best of all worlds, but that will not likely be the case since your processes were developed in support of the prior guidelines, including such things as history and exam that are no longer needed. Thus, the third step is to closely evaluate the new requirements and assess where you may have gaps in your processes and in your documentation. I've said it lots of times, I'll say it again, remember the adage that I want you to take away of how to help yourselves, and that's document, document, document. Continuing on, start educating and training your staff about possible gaps and steps to close those gaps. This includes evaluating current EMR, electronic medical record systems, and talking to your EMR vendors about what they're doing to provide solutions within the software and within your systems. Test that time element now, how you're tracking time of an office visit in your system to determine feasibility with the new guidelines. And this will often go in tandem with your EMR questions. Of course, pay attention to Medicare, AMI, and advisor updates and comments. We've been fortunate enough to work with consultants like Peak Performance Physicians or the Coker Group, among others, who have been staying on top of these types of solutions. So if you don't already have good advisors on billing issues, please take the time to find one or two who can help you work through this. Be aware and read the final rule when it comes this fall, especially as it may adjust the Medicare compensation rate or work RVU levels. And last but not least, evaluate your existing physician compensation arrangements for how the work RVU changes may impact provider income. Depending on the compensation formula, these changes could have an impact of increased compensation, that's good, but also may have an unintended consequence of impacting fair market value under the arrangement. This is especially important if you have any type of physician-hospital arrangement or any other type of arrangement that impacts compensation for a potential referral source. So while good news, you still have to keep in mind how might that impact the compensation and does that change the nature of the relationship. But when you're looking at all these things, if you can walk through this checklist, you will be in good stance to be ready for the changes to the E&M codes. And with that, wow, how time flies when you're having fun. I know we covered a lot of ground, and I know you might have questions. I know you're going to have issues. We touched on a variety of topics today and a multitude of requirements that you need to keep in mind. Hopefully they provided some help and direction as you consider how these issues would impact your specific circumstances. I have to tell you, it's so much more enjoyable to see your smiling faces during these types of presentations, so I wish we could have done this discussion in person. I do look forward to the time soon when we can do so again. And should you have any questions, please do not hesitate to reach out. You have my email address here. If I don't have the answer, I will work to at least point you in the right direction. Please enjoy the rest of your annual meeting, and until we can see each other again, please stay safe and practice the 3 W's. Wash your hands, wear your masks, and watch your distance. Take care.